individuals who are sufficiently at high risk for a specific disorder to warrant further investigation or direct action. And the ultimate objective is to reduce mortality and morbidity. And what is needed for a screening program is a suitable disease, suitable test, suitable program, and good use of resources. And this is important, and I hope this will be clarified to you in the coming 2 weeks, because you can screen for anything, of course, and you will find diseases, but in the end, if you will introduce a screening program in a population, then it has to have effect. Otherwise, we don't do it. If you can't treat a disease, it is not useful to screen, for example. But if the test is very expensive, then it's just a matter of cost effectiveness. The government won't pay for it. So keep in mind all these things when you have to think, for example, for your assignment. If it is not useful, if it is it costs too much, it isn't the right screening process. Okay. What would I like to tell you? I'm Carla van Kalle. I work at the Maastricht study, and I'm not sure if you have heard from it or not, but it is a large cohort study in Maastricht that started in 2010. And it is all about diabetes and complications, and I will use this study to introduce to you diabetes, why it is useful as a screening tool, maybe, why not, why isn't it there at this moment. So this is the Maastricht study, and it's in fact related to the lecture before about metabolic syndrome. We look at cardiovascular phenotype, at lifestyle, chronic diseases, central nervous system, public health, because that's the main determinant, of course, biomarkers. And we have a very large bio collection. In fact, it is, of course, not a screening program, it is a research program. But in the end, what we aim to is to develop screening tools for diabetes, and especially for its diabetes complications. So getting back, what are we looking for? We are looking for a suitable disease. Okay, we defined it. It's diabetes and its complications. And I will go on with the other remarks. So what is a suitable disease? So it should have serious consequences if untreated. It should be detectable before symptoms appear, and better outcomes if treatment begins before clinical diagnosis. And this is of course important. If a screening program is only useful if you can detect the disease, or if you can detect or the disease or markers for the disease before you will develop it, and otherwise you can't treat it, so it's no use to screen. So what about diabetes? It is not only diabetes. I will talk about diabetes and its complications, because diabetes on itself, the high glucose, you can treat, but the complications are important, as you heard in the lecture before. So what is it? And what are the complications? I think you know a lot about this, but I will just introduce or go on with the slides a little bit quick, and then you are all up to date. So what does it stand for? Diabetes mellitus is a collection of disease, I will come back to this, characterized by hypoglycemia with a high risk of organ and vascular damage, resulting in excess morbidity and mortality. And that is why it's useful for screening. So diabetes means passing through, so that's because of the excess of fluid intake and going out as urine. And mellitus is from honey, because it's sweet. It's sweet urine. Very formerly, the first test for diabetes was sweet urine by lack of other tests. So what is a diagnosis? I think you know all this. Glucose above 6.9, some say 7.1, random glucose above 11 millimole per liter. And very similar signs, symptoms and consequences, but different causes and population distribution. And this is because there are many types of diabetes, type 1, type 2, gestational diabetes, and even other forms. All are characterized by polydipsia, polyuria, and polyphagia, and these are the numbers in the Netherlands. And we are mainly talking about type 2 diabetes, because type 1 is, it is interesting, but not in the Maastricht study, and not if you think about screening. Still, some things about pathogenesis. What is important and what are the differences between type 1 and 2? Are you all familiar with that? Or do you know what the differences are just between type 1 and 2? I see one person that is. The others not? Or, yeah, 2. What is important? Type 1 is an autoimmune disease. It ends in severe insulin deficiency, and the only thing that will help is insulin therapy. In contrast to the type 2 diabetes, this is related to an abnormal secretion of insulin and insulin resistance. Therefore, you have a relative insulin deficiency. In the beginning, you can treat it with oral medication. After that, you get a beta cell exhaustion, and it will end in type 2 diabetes. Needed treated by insulin also. That is the difference. The one is relatively insulin deficiency, and the other is absolute. So, why is screening maybe useful for diabetes? Because it should have serious consequences, and we all know this. We have short-term complications and long-term complications of diabetes. And the main thing is that you have a higher risk for other diseases, so like myocardial infarction or cognitive impairments. The short-term complications are hypoglycemia and hypoglycemia, caused by hypoglycemia mostly by interacting with medication or in current infection. And the hypoglycemia because mismatch of nutrition and medication. Does it matter? Yes, it does matter. We identified that. And this is a Dutch study, the Warren study, which introduced this for one of the first that introduced why it doesn't matter. The NGTs are normal glucose tolerant. IGT is impaired glucose tolerant. The NBM are the new diabetic individuals, and the KDM are the known diabetes. And what you see is that the survival after follow-up is less in the known diabetes. So the longer you are identified with diabetes, your survival will be shorter. And why is this? Because we have coronary arteriosclerosis in diabetes, neuropathy, retinopathy, and neuropathy. And these are the long-term complications. You can divide these in two groups. The first ones are retinopathy, nephropathy, and neuropathy, and they are closely related to the degree of glycemia. And they are affected by blood pressure and smoking. And this is, which shows this. You're familiar with HB1AC? Do you know what it is?
It's a glycated hemoglobin.
I'm sorry?
Glycated form of hemoglobin.
Yeah. And what does it mean? What if you measure it and it's too high, what does it indicate?
It indicates the blood glucose was high.
Yeah.
For a period of time.
Yeah. Okay. So if the glucose was high in the former 2 to 3 months, for example, 11% in this case, case. The rate per 100 persons for years that developed retinopathy was much higher than in normal values of 7%. So retinopathy is highly related to glucose levels. The higher your glucose, the more chance you develop retinopathy. It's the same for all. The retinopathy was an example. This is a familiar slide with all microvascular endpoints. One decrease. Now, if your HbA1c is decreased with 1%, you get a 37% decrease in microvascular endpoints. So in endpoints like retinopathy, nephropathy, and so on. What is the pathogenesis? You have long-standing diabetes. Your proteins like HbA1c, but also like other proteins, will be glycosylated. The proteins get deposits in the basal membrane. The blood vessels get thick and leaky. Exudation and ischemia, and it ends in organ damage. So these microvascular complications are mainly seen in the eye, in the kidney, and in the nerves, and end in retinopathy, nephropathy, and neuropathy. In the end, it also results in death and disability, and that is of course important if you think about screening. That is what you want to prevent. The other complication is atherosclerosis. That's not related to microvascular complications, but to macrovascular complications. If you relate it to diabetes, it's premature and more aggressive. It associates with, especially important in nephropathy, and it's most likely intrinsic to type 2 diabetes and not to type 1. I'll come back to this. If you then look to the relation to glucose, you see that it is not 37% as on the other slide for microvascular complications, but it is only 14% decrease per one decrease in HbA1c. And that is important. So macrovascular complications are less related to glucose than microvascular complications. And this is also shown in this slide. The reduction in risk is more pronounced for albuminuria, retinopathy, microvascular endpoints, or any related vascular endpoints, as it is for myocardial infarction. It is even not significant in this study. And this is because there is you can make two causes of the complications of diabetes. There is impaired glucose tolerance, of course, an inadequate insulin secretion and the high glucose related to neuropathy, and you have compensatory hyperinsulinemia, metabolic syndrome, and cardiovascular disease, hypertension, and non-alcoholic fatty liver. Fatty liver. So there's a difference in these two pathways. If you think about screening, you should treat both, for example. And you should, if you think about screening, also, what would you like to detect? Or what are you aimed to prevent? There's all kinds of things that you have to be aware of. So what are the risk factors for macrovascular disease? So the disease related to cardiovascular disease, hypertension, and non-alcoholic fatty liver disease. There are some genetic factors and family history. We call that non-modifiable. You can't do anything about it. And you have modifiable factors: hypoglycemia, hypertension, dyslipidemia, smoking, obesity, and physical injury. I will skip this. So, is diabetes and its complication a suitable disease for screening? Yes, because it has serious consequences if untreated. Can you detect it before symptoms appear? Does anyone know? Can you detect diabetes before 1 year, 2 years? Any markers?
I think the first develops the resistance, insulin resistance, then the diabetes.
No. So you can, maybe it's possible to detect insulin resistance before diabetes develops. That should be. Maybe it's possible. It is possible, but that could be a marker for screening. And that is actually what is on this slide. There is in time, people become more insulin resistant, and as Professor Stehauer told you, in the beginning, the beta cell will produce as much as insulin as needed to keep the glucose levels at the normal level. But if the beta cell gets exhausted in here, then your glucose will start to increase. And normally, this is the time point that the diagnosis for diabetes is made. So you want to be before this diagnosis. And one of the things you can detect is insulin resistance. This is a little bit discussed before, in the lecture before. Insulin action, it's all about metabolic function, stimulation of glucose uptake, stimulation of fat storage, and uptake of amino acids. In the beta cell, insulin secretion is stimulated because there is glucose entry in the beta cell. Because of the glucose metabolism, the potassium channels closes, calcium channels open, and the granules secrete insulin. So this is one part that is going wrong in diabetes. The other thing is the insulin action, the insulin resistance. So insulin will bind, glucose split 4 vesicles will be going through the plasma membrane, and the glucose can enter the cell. So it's a combination of these two things. So insulin resistance is a decreased stimulation of glucose uptake by insulin and insulin-sensitive cells. And if you look at the same picture as we had before, then this was the point that your beta cell gets exhausted, the insulin resistance is increasing, your postprandial glucose will increase, and your fasting glucose also. So this is the time point of diagnosis, but this is the time point of onset. So if you want to screen, you have to be in this part. And there is another thing that is important in this relation. It's not only the diabetes that you want to prevent, but especially the micro and macrovascular complications. And the macrovascular complications don't start at the time point of diagnosis of diabetes, but start at the time point of insulin resistance, that the insulin resistance develops. So if you want to prevent and screen for diabetes and its complications, you have to be, even before the diagnosis, a lot of years. So probably 10 years. And then you have a right screening tool. So it is detectable before symptoms appear, but we are still looking for the right screening. Better outcomes if treatment begins before clinical diagnosis. You can treat type 1 diabetes with healthy diet, self-control of glucose and insulin. And good glucose control will help you to prevent or to, how do you say it? The complications will start later on. For type 2 diabetes, it's more complicated because you have these micro and macrovascular complications that are important. There are a lot of therapies for type 2 diabetes. But if you want to prevent the macro and microvascular complications, then you also have to do something with antihypertensiva and lipid lowering. But still, it is not yet been proven that earlier detection will improve the outcome of people with type 2 diabetes, but it seems logical to suggest that it may help. And this is what we are doing in the Maastricht study. We want to have a look at what is happening right now, and we want to follow up these people for 5 years, for 10 years, and then look what can be an ideal screening marker to identify the people at the highest risk. So what could be a suitable test? It's a suitable test for screening. It should be detect any pre-symptomatic phase. It should be safe, accurate, and acceptable and cost-effective. You can think about measures of hypoglycemia in diabetes, but as mentioned before, it's not the only thing, because then you won't prevent macrovascular complications. I think you are familiar with these tests. So you can use a random glucose, fasting glucose, oral glucose tolerance test, postprandial plasma glucose. This is a test that is becoming more popular, and you can use the HbA1c. This is a more detail what the HbA1c means. So it's glycosylated hemoglobin. It's irreversible binding of glucose, and the concentration is determined by the degree of glycemia and the half-time of an erythrocyte, and that is why it indicates the glucose levels of the past 2 to 3 months. All insulin release and insulin resistance can be measured by a clamp technique, but also by calculating the HOMA or using an oral glucose tolerance test. But if you think about screening, a clamp, for example, is not possible because it takes you 2 hours. It's very laborious. It will cost you a lot of money, so it's not an ideal screening tool. Even a HOMA, a simple insulin measurement, is very expensive. It's for example, you have to take the blood and you have to go to the clinical chemistry. You could do it, but it is. I'm not sure if the cost is cost effectiveness. And an oral glucose tolerance test is also, it costs you 2 hours time, so I'm not sure. But if you do it, then it's a good measure of insulin release, as mentioned in this slide. In the people that are impaired glucose tolerance, so before you develop type 2 diabetes, you see that the insulin release is already declined. So you could use it as a test. Another thing what you probably can use is the metabolic syndrome, because the metabolic syndrome precedes diabetes and hyperlipidemia, and it predicts a higher risk of cardiovascular disease. And especially when you have diabetes, metabolic syndrome is indicating a higher risk. And that's shown in this slide. If you have no metabolic syndrome of no diabetes, you have the lowest percentage of coronary heart disease. The prevalence of coronary heart disease is the lowest. It is comparable to if you have diabetes and no metabolic syndrome. If you have only the metabolic syndrome but not diabetes, your prevalence of coronary heart disease is increased, but it is the highest if you have both. So metabolic syndrome can maybe be used as screening tool. In the Maastricht study, we will have a look at this, all these things, because we have an annual follow-up of morbidity and mortality. We have follow-up surveys every 5 years, And we aim to provide more insight in the prevention, etiology and treatment of type 2 diabetes and other bone diseases. More specifically, we look to genetic factors, lifestyle, metabolic and cardiovascular factors, and are involved in or can predict the development of progression of type 2 diabetes and its complications. I've shown this slide before, so we look to every combination and of lifestyle, cardiovascular phenotype, or anything else. So again, if you think about screening, what is important? Important is your reliability. Is it repeatable or can it occur by chance? The validity, sensitivity and specificity. Specificity. That will be discussed by Martien van Dongen, who is coming after this lecture, or after your break, I think. And the sensitivity and specificity should be related to the detectable preclinical stage of the disease. It should be predictive value, so the population perspective on disease detection. Other important things is that it should screen or the entire population or a selected population. It is selective or targeted screening to be performed in a subgroup of subjects who have already been identified as being relative at high risk in relation, for example, to age, body weight, and ethnic origin. And the other thing you have is, so you have the entire population, selective screening or an opportunistic screening. And that can be carried out at a time when people are seen, so by healthcare professionals or for a reason other than disorder in question. And you will see this at the MD. I won't go in detail to this because you have to have a suitable program, of course, for screening, but that is more economic. You should reach the appropriate target population. There should be quality control of testing, a good follow-up of positives, and it should be efficiently tested. I think Martien van Dongen will also go into the details. And there also should be good uses of resources. So the cost of the screening, the cost of follow-up, cost of treatment, and you always have to think about benefits and alternatives. And this is related to all kinds of screening. I think you're most familiar with the cancer screenings. And even in the Netherlands or even in any Western country, there's always this balance between cost effectiveness and cost of treatment and cost of screening, so benefits or not. And if you then think about diabetes and what the World Health Organization is mentioning about diabetes, then it says that it's a long, latent, symptomatic period in which the condition can be detected. That is present in diabetes. So that is, you can use it in this way for screening. A substantial proportion of people with type 2 diabetes are undiagnosed. So also important for screening. A substantial proportion of newly referred cases of type 2 diabetes already have evidence of micro and macrovascular complications. So again, it should be useful for screening. There is a rise of prevalence of type 2 diabetes worldwide. There is serious of the immediate effectiveness of long-term complications of type 2 diabetes. And there is evidence that supporting the efficacy of intensive glucose control, blood pressure control, and blood lipid control. And there is accumulating evidence that treatment of hypertension and dyslipidemia can prevent or at least decrease the incidence of cardiovascular disease in people with type 2 diabetes. But for now on, there is no screening program for diabetes. And that is why we have, for example, the Maastricht study and other large cohort studies worldwide to get a useful screening tool for diabetes. So, diabetes is more than hyperglycemia. Treatment is multifactorial and multidisciplinary. An active screening seems to be essential for both diabetes and the complications, but it has not yet been proven that early detection will improve the outcome of type 2 diabetes. And the screening is a dynamic topic in which new evidence will become available and further considerations will arise over time. So this is an example of diabetes. I think the most familiar disease in your study even, I think it's been discussed a lot. It's important in the Netherlands and in the Western countries, also in other countries it will develop, but there is still no screening tool, but it is the major cause of death, one of the major causes of death in the Western countries. An example of screening, which will be followed by other diseases that are somehow more clear. Screening tools are available, for example, for cancer, for some kinds of cancer. And it will be discussed by all the other lectures that will be given in the next 2 weeks. If you have any question about this lecture, of course you can ask it right now. If there are other questions about the first 2 weeks of this module, please use the Blackboard or write an email. And I want to thank you. Any questions?